Good morning, good afternoon, good evening, wherever you are. We are delighted to have your participation in the first of the webinar mini-series that we've arranged here at Imperial College London, and particularly thrilled to bring to you some world-leading modelers to give us some insights into the interface between modelling and policy decision-making in the context of COVID-19. I will be the facilitator for today's webinar. Just by way of introduction, my name is Nim Arinaminpathy. I'm a reader in mathematical epidemiology at Imperial College, London. And I also wanted to acknowledge the really important contribution from Natsuko Ime, Juan Vesga, and Sabine van Elsland for all their incredible work bringing everything together. So, to begin with, I just wanted to describe to everybody very briefly the short course that we hold at Imperial College in London. And this is quite important background for this specific webinar. This short course is an annual 2-week residential course that we hold at Imperial College London. And you can see here in this flyer, we originally had ambitions of holding this course as usual in September of this year, but because of the, of course, the ongoing situation, we've had to postpone this to 2021. And so please watch this space for the holding of this short course in September of next year. We're basically having this mini series of webinars now in place of the short course, and we're quite excited to bring this expertise to folks interested in the role of modelling. But as you can see from this flyer, the short course itself is really aimed at public health professionals who are interested in learning about the basics of infectious disease modelling. And you don't need to have a background in advanced mathematics. The course is designed around folks who have not had any recent training in this. And we should also mention we have at least one scholarship available for attendance from developing countries to join as well. It's been very well received in the past, so please do keep your eyes peeled for announcements for this course for the next year. But anyway, coming back to the webinar today, we're delighted, as I mentioned, to have with us today Professors Neil Ferguson, Gabriel Lung, and Azra Ghani. And these are all, as I mentioned, really leading lights in mathematical epidemiology, and specifically in the response to COVID-19. The way this webinar will work is that we'll have each of these speakers giving a 15 to 20 minute talk with slides, and then we'll have 1 or 2 minutes at the end of each of these talks to address questions from the audience. And then once all 3 speakers have finished, then we'll open the floor to a broader Q&A session amongst amongst all of the speakers that have presented. And so as participants, what you'll see is in the corner of your screen, probably towards the upper right, 2 overlay speech bubbles with a question mark in them, and basically that's the Q&A button that you would use to enter questions for the speakers. So we do encourage you to take part to address any questions from today's speakers. The questions themselves will be moderated and also facilitated by myself, and we hope you enjoy the webinar. So. Let me just jump straight in then and introduce the first of our speakers, who is Professor Neil Ferguson. Neil is the founding director of the MRC Center for Global Infectious Disease Analysis, the NIHR Health Protection Research Unit for Modelling Methodology, and the Abdul Latif Jamil Institute for Disease and Emergency Analytics at Imperial College London. His research aims to understand the epidemiological factors shaping infectious disease transmission in human and animal populations, and a key practical focus is in aiding policymaking and disease control through intervention modelling. So he uses models as contingency planning tools for emerging human infections, and notably COVID-19 this year, as well as previously MERS coronavirus, Ebola, and pandemic influenza. Excuse me. So he also undertakes research on the dynamics and control of vector-borne diseases, including dengue, yellow fever, and malaria, and their evolution. And he advises the UK and US governments, the WHO, and the European Union on emerging infections and infectious disease modelling. Neil, over to you.
Thank you. I will just share my presentation. It's a pleasure to be here this afternoon. I'm going to just focus mostly not on looking back, but really looking forward, saying what have we learned in the pandemic thus far and what can we expect in the next 6 months. And I'll have mostly a focus on high-income countries. My colleague Azragani will talk about work we're doing in learning in her presentation. Just to acknowledge the funders at the outset, principally the MRC, Community Jameel, and then NIHR UK funder. So where are we today? Well, clearly the epidemic and the pandemic is spread to every country in the world and has peaked largely in most countries, gone down because of the influence of controls in many countries. And now we're seeing in some countries of the world origins transmission. So far we have something like 870,000 reported deaths. The true figure is almost certainly somewhat higher than that. Not all deaths are necessarily detected. Certainly the number of confirmed cases, the number of people who've been infected in the world is much higher by this point than the officially reported figure on the WHO website of 27 million, as we know that many countries struggle with testing capacity. It shows work done within the centre on tracking the epidemic in different continents and doing real-time modelling. It's just to say that whilst, and these are cumulative deaths over time, normalised to count from the time point where each country reported cumulative 10 deaths, the fact the curves have turned over, and these are on a logarithmic scale, indicates that transmission has slowed in most countries. There are a few exceptions there you'll see on the graph. But in countries has transmission stopped. Whilst the flatter these curves, the lower the level of current transmission, we still see many countries where we have ever increasing case numbers. One of the key messages I want to get across today is that in most countries, particularly most high-income countries of the world, we're still at a very early stage of this pandemic. So lockdown in countries such as most of Europe, some of Latin America, to some extent, a very successful measure at curtailing transmission and minimising mortality. But because it curtailed transmission, the proportion of the population which has become infected thus far, shown in the right-hand plot here, these are serological surveys conducted in individual countries or in regions of those countries, and you'll see that there's no point which is higher than about 15% on that graph, and that corresponds to what we estimate seroprevalence in London to have been after the first wave of the pandemic. Most seroprevalence surveys come up with figures even lower than that, so only a small portion of the population has yet been infected. Perhaps the most heavily affected high-income setting was New York State, which got up to about 20%. And whilst there's debate about the threshold of immunity which would be required to get so-called herd immunity, it's probably of the order about over 50% of the population would need to be infected, and so we're a long way off that. On top of that, of course, we now know immunity transient to this virus, so the notion of herd immunity is perhaps challenging. So there's a long road ahead. Very early in this pandemic, all the way back in February, we published the first estimates of the lethality of this virus, and particularly of the infection fatality ratio, namely the proportion of people infected who will be expected to die. But that single number is a bit of an oversimplification. In reality, we know for this virus, depending on what age you are. And that's shown in this graph here, published in Lancet ID in April, I believe, based on that early analysis, showing that that really the fatality ratio in the elderly, those over 80, is much, much higher than, for instance, in younger age groups in the population. And this is a pattern we've now had verified in data from multiple countries. And this level of severity puts this virus in the same ballpark the Spanish influenza virus. And certainly if we think about how Spanish flu, if you rerun today with modern healthcare systems, might manifest in terms of mortality, the overall level of mortality might well be similar. Of course, there was a big distinction that Spanish influenza H1N1 affected all age groups roughly equally. So the challenge the world has faced in this pandemic is of a highly infectious virus. The reproduction number of secondary cases per case somewhere in the 4 epidemics which double every 2 to 5 days, probably 3 to 4 days. Peak is the best estimate in the absence of control measures, with a reasonably high lethality, about 1% of those infected, and a healthcare demand which is some multiple of that, maybe 2 or 3% of those infected requiring hospitalizations. And quite simple modelling can demonstrate, just based on those numbers, that without control measures, health systems in any country of the world would be overwhelmed if the challenge is that we only have control measures for this virus thus far, which rely basically on social distancing or on contact tracing. We have no vaccine or drug, well, certainly at the beginning of the epidemic, effective drugs to give people. And so we had 2 basic strategies relying on these so-called non-pharmaceutical interventions. One called mitigation, which is attempting to manage the epidemic, so-called flatten the curve, but not necessarily stop it altogether. And potentially after years, you might build up herd immunity. And the other, which most countries have gone for, is suppression, stopping or delaying the epidemic, implementing measures which are strict enough to actually reduce the reproduction number below 1. The challenge with the suppression, though, whilst in many high-income settings, which is in the United States, most European countries, it has worked as intended, but it was enormously costly economically, and therefore in the long term, taxing measures risks that all those gains we made through the very costly intervention being lost. All suppression has done in some sense is delay the epidemic, not eliminate the virus from the human population. And so even all the analysis and modelling would suggest that any gradually, as you relax measures, at some point transmission will creep up again, and the reproduction number will go of 1, and we'll see a growing epidemic. And that's the situation we're in. Probably is still slightly unclear, but certainly in many European countries, and have been in various US states for a longer period of time. So the only alternative to then episodic lockdown or implementing social distancing measures once you see case numbers go up is trying to stop chains of transmission before they really get established in the community. And that is why most countries have had enormous emphasis on so-called test and trace strategies, clusters of transmission, and then imposing very localized measures which are clearly less costly than measures which are implemented at a country scale. Some countries have been much more successful than that than others. I mean, South Korea, Taiwan, other countries, Germany, put in place a lot of testing capacity very early. Conversely, some other countries, notably the UK, but the UK is by no means alone, struggled to put in early large amounts of testing capacity and had to rely. Asra is going to talk to this in much more detail, but whilst we talk about high-income settings struggling, countries in the European Union, for instance, or North America struggling with the economic impact of this virus, and healthcare systems being challenged at the peak of transmission in countries such as the UK, Spain and Italy, spur a thought that most of the world is in an even poorer position in terms of both healthcare infrastructure and ability to respond to surges of healthcare, in terms of their economic capacity to absorb the shock caused by COVID-19. So then looking forward in this context of case numbers which are creeping up, and in a few countries being followed behind by hospitalizations creeping up, what do we need to maintain control of this virus over the coming months as we move into the winter in the Northern Hemisphere? I'm going to highlight three things. First of all, and I'm kind of an epidemiologist, we need to be able to track transmission with ever greater resolution and predict trends, and that requires a testing and tracing infrastructure up to the job and the challenge, and analytical tools which allow us to predict forwards. We want a better quantitative understanding of transmission than we currently have. What we'd like to be able to do is be able to distinguish between those measures which actually work and reduce transmission and those which don't. And we struggle at the moment with data and in some sense scientific concepts. And if we had that better understanding, we'd be able to move to much more predictive mechanistic models of locally targeted interventions, optimizing what we do when we see the next outbreak. So we looked at, back in March, a simple example of an algorithmically determined policy, which was called adaptive triggering. And this is where we predicted back in March that lockdown, but that once it was released and measures were relaxed, we'd see a resurgence of transmission, which would at some point require interventions to be put back in place. Maybe not to the same level, but sufficient to get the reproduction number below 1 again. And so we modelled this kind of on-off pulsing of interventions based on a certain trigger, and we looked at healthcare demand, which is the most important trigger if you want to kind of reduce deaths and reduce the impact on the health system. I'm doing this in terms of tracking transmission. We've invested a lot of time and effort at Imperial in developing more nuanced models of transmission, which can actually track the data in real time. And we're using models which can synthesize, integrate data from multiple sources. And so this just shows simple example work by Mark Bagel and colleagues, including myself, fitting a model in real time using particle MCM system with serology data shown at the top of this slide in different regions, but also then to hospital deaths both in the community and in care homes. And these are the sort of models we've used over the months to generate real-time predictions for the UK government and estimates of the reproduction number through the SPI-M committee, which then feeds into SAGE. Fitting these very detailed models, though, is probably only feasible once you have enough data at quite a large scale. And here these are fitted to different English regions. We're also interested in what's going on at a much more local. And here work by Axel Gandhi and Sam Batt and colleagues at Imperial. This is now a public website. Unfortunately, I didn't put the link in, but we can post it in the chat later. This shows the testing data in the UK, which is publicly available now, but then analyzes that in real time to give an estimate of the probability the reproduction number, for instance, is greater than 1 and the case numbers are increasing, and give projections of cases over time for a few weeks ahead. It's been made even prettier now in the public release. And as well as looking at maps, you can then look at tables and can drill down into individual areas to see the trajectory of the epidemic in your vicinity, and a fit of our models to that trajectory in terms of what the likely trends are going to be in the next few weeks. I talked about getting a better understanding of transmission at a fine scale, and we're also doing work on that, part of collaboration with other colleagues at Imperial focused on Italy, but also many other collaborations. For instance, the REACT study run by colleagues at Imperial to track transmission in the UK at a fine scale and look at prevalence in the community. We're trying to get estimates of some fundamental quantities. First of all, we don't really know as much as we would like to know about fundamental things like the basic reproduction number of this virus in between one round of infection and the next round. But most importantly, we'd like to understand, which types of transmission and types of contacts in the population pose most risk of transmission. What's the relative contribution of household transmission versus primary schools versus secondary schools, different workplaces, for instance, and leisure venues. We don't know as much as we would like about how much risk to people who are infected compared with those with symptoms. And answering these questions requires very detailed data. Some of the data from Italy is being shown here, contact tracing studies and community prevalence surveys, where we also monitor our population behaviour. And the aim of doing that, and this shows some other work by Sam Batt from a few months ago, which tried to fit both the trends in mortality in the first wave in different European countries with timing of interventions. We'd like to go beyond that to a model which doesn't rely on fitting country-specific regression parameters for that sort of fit, but can actually predict, out of sample, predict what the impact of interventions are going to be. And in order to do that, we need a better mechanistic representation of those interventions in simulations, in models. Exactly what does each intervention do to transmission? And this is what we're aiming to do now with both fitting using parallel MCMC, the microsimulation we used back in March, but now to data not just from the UK, but also from Sweden, parameterized with data about what interventions were put in place in those different countries. And that tells you something, because Sweden obviously adopted different measures from the UK. And so by comparing the effect of these different measures on the epidemics in their respective countries, you can learn something about which measures are most effective. Certainty, very relevant now that schools have reopened across Europe, is what role children play in transmission. We do have increasing amounts of evidence that children under the age of about 13 are rather less, certainly much less likely to get symptoms, but maybe even less likely to get infected. We have poorer data on teenagers though, and certainly by the time people are 18, it appears they transmit, and just even if they're severely ill. And so a key question is what will the reopening of schools do to transmission at a community level? Most models predict that reopening schools is going to lead to some resurgence of transmission. The key question is quite how much. Probably almost certainly secondary schools and universities will contribute more than primary schools. So the things we do is, for the UK government, as well as multiple other groups in the UK, is generate so-called reasonable worst case scenarios for government planning purposes. These are not predictions, I should say. These are intended to be scenarios which healthcare planners can plan bed capacity against, for instance. So, I mean, this shows work we did for the UK reasonable worst case, which will be publicly released shortly by the UK government, which was looking at a range of scenarios, basically in September, as how transmission might pick up in the coming months. But probably more useful is to talk through those scenarios from a verbal perspective. It's likely, for instance, that high schools now having been opened, that is going to lead to the reproduction number picking up, maybe to as much as 1.5, 1.6, and increases therefore in case numbers and eventually hospitalizations in most areas of the country. It's possible stresses on testing, despite testing capacity being a lot greater than it used to be in many European countries. And then there may well be challenges in terms of the population's acceptance of reintroduction of measures, both economically and just because people are exhausted and the political will may wane. And so we may see an increasingly difficult scenario where, whilst we don't have a completely out of control epidemic, we do see gradual increases in cases over time and hospitalizations, which it is hard to maintain control over. It's going to be slower moving probably than pre-lockdown, but that doesn't necessarily mean the eventual impact of it of such a second wave could not be significant. So that's just a whistle-stop tour. I mean, I want to end kind of maybe more positively than that last slide. I mean, it is remarkable what the global response to COVID-19 has achieved. This is the first time that the has implemented measures to try and effectively stop a pandemic in its tracks. And whilst it hasn't been completely successful, it has been partially successful and has undoubtedly saved many millions of lives. But what we've done is effectively delay transmission, not stop it permanently. If we lift measures, then transmission would be predicted to resume. And therefore, we need measures which can control transmission long term, testing and travel. I'd also like to say this pandemic is in its early stages. Perhaps less than 5% of the world's population has been infected, maybe at most 10% thus far. The number changes because in some countries, for instance India, we have seen quite a lot of transmission. But there are risks where we are now, that the economic impact and fatigue will mean that there's no longer the political will or population acceptance of reimposing measures necessary to maintain, and that's gains we've seen in the last few months being undone, at least partially. And so we desperately need to monitor and understand transmission better to ensure that we have interventions available in the coming months which can target transmission more precisely, faster and at less economic cost. Thank you.
Thank you so much, Neil. That's a really useful and valuable whistle-stop tour of all the work ongoing, as well as a reminder of the fact that we have paused but not stopped the pandemic. So I'd like to thank the audience members for questions that have been coming in. Lazaro asked a question about Africa, but what I'm going to suggest is, Lazaro and other colleagues interested in low and middle income settings, perhaps we could circle back to these questions after Professor Ghani's talk at the end of today's session, because she'll be talking specifically to low and middle income settings. But Neil, for you, perhaps I could ask you Andrew Shattuck's question from SwiftTPH. Which is, are you currently considering any uncertainty with regard to immunity profiles? For example, the effect of waning immunity on herd immunity threshold, also given the available evidence and literature. And secondly, do you have any insights into how efficient contact tracing could be in developed countries for given levels of the effective reproduction number?
So I'll answer the second question first. My guess is that contact tracing, if done efficiently enough, can reduce the reproduction number by about 20% on top of what we all recommend, which is namely that symptomatic people stay home and don't go out. And we came up with that estimate. The London School has come up with a very similar estimate based on analysis of contact patterns in the population and analysis of the delays inherent in any testing and tracing system. In terms of the former question, is a very good point. We have started to look at that, and clearly it just makes things worse if they've long-lived herd immunity. But at the moment, our projections are that even if waning happens, even at the 6-month time frame, it doesn't make an enormous difference to the projections we currently have, just because for most European countries, we are not projecting more than a small percentage of the population having been infected thus far. I think the immunity picture is a very complex and interesting one, though. It's quite likely immunity is going to affect disease and protect against disease for longer than it will protect against infection, which opens up a key question, namely, what is the contribution of asymptomatic people to transmission? Because if you still have protection against disease and you need symptoms to transmit, then maybe waning of immunity has less impact than it would in other circumstances.
Thank you. And perhaps just one more question, if you don't mind. So Joao Ziroldo asks, could you comment more about the importance of public health community service in contact tracing, especially in countries with and without strong social healthcare systems?
Yes, this may be more for kind of Azra to comment on. I think I answer the question indirectly. I think one of the main goals of contact tracing is less about isolating exposed individuals, but about understanding where transmission is happening and picking up clusters of cases early on. And this is a lesson learned from South Korea. And I think that can be done from a community level. It can also be assisted with things like apps as well. And contact tracing is something which requires community engagement, even if it's done by medical professionals. I mean, we need people to buy into the system and understand what it's for. And certainly it requires some training, but not doing contact tracing doesn't necessarily require you to have a medical degree.
Fantastic. Great. Thank you very much, Neil. And we look forward to having you back for our overall